Yeah, so I think for many patients in the second line and beyond, I think first about what was their experience with frontline therapy. Was that a long remission? Is it something that they were, um, the performance of that frontline therapy performed as well as we would like? So, for example, in our patients that had a short remission or were maybe even refractory to frontline therapy, those POD24 patients, we tend to go with immunotherapy-based approaches. For patients that might have had a long remission and otherwise would be then expected to do well with most other therapies in the late line settings, I think a lot about the balance between side effects and the logistics of delivery. So trying to explain to patients exactly how we give treatment. Is it important for them to be on for a short period of time? Are they willing to come for maybe we'll say more intensive visits up for a short period of time. Sometimes our treatment regimens now in the second line can even include weekly infusions for a while. Is that something that's a concern or a barrier for them? And I think a lot of these discussions tend to be centered around a backbone of lenalidomide and rituximab-based therapy, but the questions we're starting to ask are perhaps about either a T-cell engager like epcoritamab in combination with lenalidomide and rituximab or a monoclonal antibody like tafasitamab. And so those are slightly different in terms of the schedule, how they're given, the side effects that patients might experience early on with treatment. And then for most patients today, I would say we are not usually repeating chemoimmunotherapy, but for a small number of patients, perhaps those that had very, very long remissions with frontline chemoimmunotherapy, for whom, maybe there are logistical reasons they want treatment that's given in much more spaced out intervals where we may consider chemoimmunotherapy in the second line, but that tends to be a very small number of patients these days.
Great, thank you. Our next question is, what patient-specific considerations should practitioners consider to select the appropriate second-line therapy?
Yeah, I think there's a number of factors there, but often, again, I would think about POD24. So, did the patient have disease progression within 2 years of that frontline therapy? That's a patient population that I would favor treatment in a clinical trial or with immunotherapies. And then, really, again, the preference of how treatment is delivered and what the patient's goals are. I think, for example, our younger patients, maybe they're in their 60s at the time they need second therapy or later. They may have very different goals than, say, a patient who's in their 80s. And so this is, I think, an area where we really have to spend time to think about the patient's values and then also the biologic characteristics. Is the relapse a high tumor burden relapse, or is this a low tumor burden relapse? Sometimes we'll also see patients with relapse that's isolated. Is that a patient that might benefit from, say, something like radiotherapy, which can be delivered over a short period of time? So I think all the factors we think about in the frontline setting are important. And additionally, we think about that POD24 status.
Great, thank you. Next question, how often are you offering R squared, i.e. lenalidomide rituximab, as a chemotherapy-free frontline option? And what does the patient profile look like when you recommend it?
Yeah, it's a great question. Many patients do come asking about potential chemo-free options in the frontline setting. And there we can consider the use of lenalidomide and rituximab that's based on a clinical trial called Relevance, which didn't meet its primary endpoint, but essentially showed that outcomes were similar for that combination as chemoimmunotherapy. I think what's important for patients to recognize in that setting is that chemo-free doesn't necessarily mean side effect free. They are different side effects. And so I tend to spend a fair amount of time describing how the treatment is given, what side effects differ between, say, a chemotherapy-based approach or R squared. And then importantly, I think for that frontline use of R squared, that is a relatively extended treatment course where the combination of the lenalidomide and rituximab is given for up to 18 months, and then the rituximab is given as a maintenance therapy until up to 3 years. So I think many people are surprised by the length of therapy that really defines how we can give R squared in the front line. So those are the things I think about. And I think once the patient has that information, many will then kind of choose which therapy aligns more with their values. There isn't a specific biologic category that I would say I preference for one or the other. And so this is another area that's really driven by patient values and preference in terms of how treatment is given.
Okay, great. Dr. Patel, I want to give you a chance here if you want to take a drink of water.
Sure. Thank you. Thank you.
Of course. Our next question is the InMind trial. The InMind trial showed a 57% PFS improvement adding tafasitamab to R squared in relapsed refractory follicular lymphoma. Where do you see this drug fitting in the treatment algorithm?
Yeah, I think the inMind trial is a really important trial. I think for some years, basically for since 2019, many practitioners in the US use R squared in the second line and beyond. And so what the inMind trial showed us is by adding one medicine, tafasitamab, a CD19 monoclonal antibody, we can substantially improve the progression-free survival. But importantly, that trial also showed that there really didn't seem to be a substantial increase in adverse events, maybe a slight increase in infectious rates by adding a third drug to the doublet of R squared, but not much more than that. And so I think this is an important trial to consider and discuss with patients. If we're thinking about R squared already, adding a third medicine is relatively straightforward. Tafasitamab is a medicine that's very well tolerated in my experience, can be given in most community oncology practices. It does need to be given weekly for a while, so that's an area that we often talk about with our patients, but I think this trial represents a really important advance on the doublet alone of R squared.
Great, thank you. Our next question is about BTK inhibition. How would you determine if BTK inhibition was appropriate therapy for relapsed refractory follicular lymphoma?
Yeah, this is a great question. We've seen BTK inhibitors really, I think, revolutionize the treatment of all kinds of B-cell lymphomas across the spectrum, save for largely follicular lymphoma. That was until we saw the results of the phase 2 randomized Rosewood trial. So Rosewood is a trial specifically looking at patients treated with zanubrutinib and obinutuzumab compared to a control arm of obinutuzumab alone. And that trial took place in the third line and beyond setting. So I think for patients perhaps who are later line follicular lymphoma that you would think about treating with a monoclonal antibody alone, that is the population in whom maybe zanubrutinib and obinutuzumab may be a reasonable option. It's not clear exactly why zanubrutinib may work as well as it did in Rosewood compared to, say, other BTK inhibitors where we've seen the single agent activity be relatively low. There's some consideration that perhaps it's having an immunomodulatory effect, so it makes the antibody work better. But I think that's usually where I think about it, is in patients where I would think an antibody alone is a reasonable treatment. That might be somebody who's perhaps older or frailer or has very specific toxicities that you want to avoid, that may be challenging with the use of a medicine like lenalidomide, for example, things like peripheral neuropathy, cytopenias, where some patients have been intolerant to lenalidomide before.
Great, thank you. At this point, I'd like to transition over to Ernest, asking some questions. I will stay right here, writing
Sure.
down time codes as I have been. But I think this is a very valuable experience for Ernest, so passing it over.
Thank you.
Awesome. Yeah, thank you so much, Dr. Patel. So I'm going to get started on my questions. So let's get to it. When choosing between bispecifics, how much does treatment duration affect the patient's willingness to start therapy?
Yeah, it's a great question, Ernest. I think we have a number of different bispecific antibodies available to us in follicular lymphoma, two in the US, mosunetuzumab, which is given largely in an interval of roughly every 3 weeks after step-up dosing, epcoritamab, which is given largely weekly for some time period, and then decreasing time intervals thereafter. And at least in the third line and later setting, is approved as a treatment to progression therapy whereas mosunetuzumab is given for fixed duration. So there are differences that are meaningful, I think, to the time the patient spends in the clinic, as well as how frequently they come into the clinic. And that's something that I really try to emphasize to patients and let them choose or share what is most aligned with their sort of value. We don't have any head-to-head data for these two agents, and they generally look comparable when we're looking at things like response rate, toxicity. Maybe mosunetuzumab is slightly less risk of CRS during step-up dosing. And so these are the things that I often try to communicate to patients, and they will often kind of share their own values and what kind of their preferences are in terms of a fixed duration of treatment versus an extended course of treatment.
Awesome. Thank you. Next question. For patients who may be candidates for CAR T-cell therapy, when is the ideal timing and process for referring to specialized treatment centers?
Yeah, CAR T-cell therapy, I think, is a really also important tool in the management of relapsed refractory follicular lymphoma. We have 3 CAR T-cell therapies approved in the US, all in the third line and beyond setting. These are autologous CAR T-cells, meaning we have to collect cells from patients and manufacture the CAR T-cells. So they are not therapies that are immediately available to the patient. So I think anytime a patient might benefit from a CAR T-cell therapy, the earlier they are referred, the more able we are to, one, educate the patient on what CAR T-cell delivery actually entails. There are certain requirements that many centers that deliver these therapies have, including having a caregiver with them during the period of treatment. The time that patients spend at each center is starting to vary a little bit, can be as short as, say, 2 weeks, but sometimes even up to 4 weeks at some centers. And so these are all things that we would love to talk to patients about upstream of their treatment affecting their health. So I often tell folks that the earliest time to send patients is as soon as there is a scan that suggests they might have recurrence, and then we have plenty of time to be able to educate the patient on how CAR T is delivered and how that compares to other therapies that may be available to them.
Yeah, awesome. Thank you, Doctor. Next question. Higher grade CRS and ICANS with axi-cell versus Tisa-cell or lyso-cell are well documented. When you select between them in practice, how much does toxicity profile drive the decision versus expected efficacy?
Yeah, it's a great question. Again, we have multiple medicines in the class, and we don't have direct comparisons in clinical trials. So we have to infer the differences and discuss those with our patients. I do think increasingly we find that one, CAR T-cell therapies are safer and safer to manage no matter which product we use. So I feel comfortable using all the available products and talking to my patients about them. I think probably in my experience, what I have found to be most impactful for patients is 2 things. One, the concept of higher risk CRS that requires hospitalization can be challenging for some patients. Many centers around the US deliver outpatient CAR T-cell therapy, and patients may have a preference to try to stay out of the hospital. So that might be a factor that they're thinking about. Typically, we see a lower rate of overall CRS and high-grade CRS with the use of Tisa-cell or lyso-cell. The other is really neurologic toxicities, or what we call ICANS. Those 2 we also see in differing rates, so higher overall for axi-cell and a slightly higher risk of high-grade neurologic toxicity with axi-cell. So in my experience, many patients might preference a product that has a safety profile that allows them to stay out of the hospital or even have a chance of not experiencing that side effect entirely. And so that has been at least my experience in how patients might think about these products differently.
Yeah, makes sense. Awesome. Next question. Walk us through your recent relapsed refractory follicular lymphoma patient who received CAR T or a bispecific. What drove the choice between them in each case?
Yeah, this is a great question. So we recognize both treatment platforms are highly effective in late-line settings. I think often what may motivate somebody to choose, say, a CAR T approach is that while there's coordination and it's not typically one and done in the sense that you come in, you get the treatment right away, and you're done with it. At least once we have coordinated the CAR T cell delivery and the patient has received that therapy, there isn't an ongoing treatment that is given. They aren't coming to the clinic for ongoing infusions. And typically, most patients do very well after their initial period of time. We do need to monitor for things like infections, et cetera, and they may need to be on some medicines to help reduce that risk. But I find that many of my patients who elect for CAR T cell therapy, say instead of a bispecific, are very much interested in that, what we call very short duration treatment approach, right? They want that CAR T cell therapy, and then they don't want to have to come into the clinic for treatments long term. The other, I would say, which is a more recent phenomena, is we now have 5-year plus follow-up data for two of the three CAR T cells that are approved, axi-cell and tisa-cell, which show very, very durable outcomes, and perhaps the hint that these therapies may be curing some fraction of patients with follicular lymphoma. It's hard to define that number exactly, but the potential of a curative outcome, I think, also motivates patients to think about CAR T cell therapy in follicular lymphoma. We don't yet have that long-term follow-up data of a similar time point for bispecifics, so we don't know if those two also lead to curative outcomes. But in my experience, that might be the difference between patients that are selecting CAR T cell therapy. In the converse manner, patients that might preference a bispecific antibody may have different values. They may want to start treatment probably sooner, and so bispecific antibodies are often things that we can technically pull off the shelf and give patients. There is some step-up dosing required, but that may be a motivator for some patients. And for some patients, it can be that they can receive that therapy closer to home. And so they may not necessarily be able to access a CAR T cell therapy close to home. They may need to travel to do that, but they may be able to receive bispecific antibodies in their own community. And there are certainly a growing number of community oncology sites around the US who are delivering bispecific antibodies in non-CAR T or non-cellular therapy centers.